First of all, I want to say that I have no conflict of interest with the PhD or with any surgical. Sorry, I can connect my computer. Okay. So I want to start with this interesting study. I suppose most of you can know it. It's an Italian paper published last year, who shown an important change in trends in hemorrhoid treatment, evaluating the most common treatment for every grade of hemorrhoids. And we can see in grade 2, the most common is the rubber ligation, with a low decrease in the last few years, and with a higher trend to increase with the Doppler artery ligation. In grade 3, we can see an important increase of this artery ligation, followed by a high decrease of the STAR procedure. However, the Milligan-Morgan procedure is still the most used. As we can see in this picture, the trend for in the right side, the trend for the following years are to increase the PhD procedure and to decrease the Milligan-Morgan. In grade 4, the boss is always the Milligan-Morgan, but in my opinion, the importance of this paper is not only to show the trends of surgeons to perform the surgery, it's also the trends to what patients are asking to us. Because are we, one question related with what Professor Naldini has said, are we doing right with our patients? Are we treating properly to these patients? For example, is one of the pioneers with the biomechanic legs, with the same procedure than older surgeons treat people in 1930, when Milligan-Morgan described these techniques. And are the actual patients asking the same result than in 1930 patients asked to Professor Milligan-Morgan? I think this is the key for the innovation and the new technologies, especially the Doppler artery ligation. The success is because the patients are demanding other things. So most important, are our patients now going to accept the invalidating postoperative pain that Milligan-Morgan procedure? As all you know, the transanal hemorrhoidal dearterialization was described previously, but it was common by Professor Ratto, who described in 2005 this procedure. All these videos are property of Professor Ratto, with a special proctoscope with a Doppler, which is inserted in the anal canal. And we can select the points where the branch of the hemorrhoid artery was, mainly in the 1, 3, 5, 7, 9, and 11 o'clock with the patient in lithotomy. After that, we make a stitch in where the ultrasound makes more height. Here we are. And after the stitch, we make a seat suture with a continuous suture. Okay, all you know that. The benefits of these techniques was that there's no excision of the skin, so there is symptomatic improvement with less pain. The first 1,000 patients described by Professor Ratto were in 2017 with good results. We can see that the postoperative complications are very low, mainly the pain and the tenesmus. But all the patients relate that at the end of the follow-up, they have solved more of the problems. And symptomatic recurrence was in 9.5%, mainly because of prolapse, as the previous speaker said, is one of the most important recurrent symptoms. We can see that the main recurrence was in grade 4 with a final reoperation rate of 7%. And they identify what are the patients with this 1000 series, what are the patients with a high recurrence at the younger age, the grade 4 disease, and high arterialization. We can think that these results are because this is the initial group and this is the descriptor of the technique. But we can see that this systematic review made in England in 2013 described more or less the same results that have described Ratto in his paper, with a poor recurrence rate of 70.5%, nearly to the 80% that have described Ratto, and with a reintervention rate very near to the Ratto description with 7%. Here the reintervention rate was 6.5%. So the results sought by Ratto are very according to the literature. So that's true with the techniques. Okay, to prove the idoneous technique, we have to compare with other techniques. For the grade 2 and 3, the rubber ligation, we know that it have a very high successful rate with a low also with a high also recurrence rate, and there's no comparison in this meta-analysis of the Cochrane with the Doppler ligation is with hemorrhoidectomy, but the rubber ligation are less effective for 3 grades hemorrhoidectomy. When we compare in the Habler study that have previously presented with the THD, this study is a multi-center randomized study of 17 surgeons in NHS. We can see that the recurrence that are very high in the rubber ligations and it needs additional procedure more than the HAL. The symptoms, the complications, the quality of life are similar to between both techniques, and of course the HAL have a higher cost but lower recurrence. So with this low recurrence, we can say that the cost also will be contained. The same group have developed a cost-effective trial comparing both techniques with the same data, and they achieved that at least the cost of the HAL procedure over the rubber ligation was about £1,000 per patient, which is not so high. Comparing with other techniques, so you know that Raffaello is infrared procedure, and compared with the HAL ligation, there is a random control trials who assess efficacy lower than the HAL for the infrared coagulations, with higher complications, only lower hospital stay. Other techniques for the grade 2 and 3 is the laser, who have not any comparison with the Doppler ligation, but we can see in this study that the results between the preoperative and postoperative periods are really good, with 90% of solved symptoms and 90% at the end of the follow-up. For the grade 3, we used to use the PPH procedure. This is an article of our group, but now we are decreasing the rate we are using, especially because we have detected in the long follow-up tenesmus, persistent pains, and problem with the continence, even if we didn't find any difference in the postoperative state of manometric values. 1% of our patients at 5 years evolution refer a soiling. So at the end, the recurrence rate we have achieved in this area was 7%, very near to the Ratto results. To compare this technique with the Doppler ligation, there is this randomized trial of 10 hospitals here in Italy, only for hemorrhoids grade 3, with the early minor complications and late complications less in the Doppler ligation. And also, there's no difference in pain in residual hemorrhoids or in interventions for these patients compared to the PPH. So at the end, only the postoperative state that was higher in the PPH and obstructive defecation, which is higher also in PPH, with no difference in postoperative incontinence and improvement of the quality of life. So we can thought that these both techniques are more or less very similar in terms to recurrence and complications. What happened with grade 4? This is our experience of part of our group. This is a single center longitudinal study comparing the TAG with Milligan Morgan of Ferguson, but made by ligature. You know that the ligature relate less postoperative pains, and the 30 postoperative surgical morbidity it was higher in the THD group, but with no significant difference in bleeding, prolapse, or pain compared to the Milligan Morgan. And it's important that the further surgical procedure that was necessary in Milligan Morgan were higher than in THD, so more patients require a reoperation than in THD. The fecal incontinence, of course, was higher in the Milligan Morgan. As you know, it was a defect in the internal sphincter. And it's very interesting that analyzing separately grade 3 and grade 4 hemorrhoids, there was no difference in the result for patients for 4-grade hemorrhoids, and for patients with 3rd-grade hemorrhoids, the THD procedure appears better to reduce the symptoms than total excisional hemorrhoidectomy. So these findings are very, very hopeful for the THD procedure. We continue this study now in a multi-center randomized study in 6 hospitals in Spain. Compare also the Milligan Morgan with the THD with 8 patients, only in hemorrhoids 3 and 4. And we discovered that the need for analgesia in 15 days at the postoperative was really high in the ligature procedure than in the THD. And the main day of stop analgesia conception in THD was on day 10 against the ligature, which was in the day 15. So 5 days more, the patients have more pain and needs for analgesia. Comparing the main average pain, it was higher in the Milligan Morgan procedure for the first and the second week without differences, and we didn't find differences in the postoperative complications, in the use of laxative, patient satisfaction, basic score of incontinence, hemorrhoid symptom, return to work, or quality of life. So we can defend that both techniques are similar with the result. At least THD is not inferior to Milligan Morgan with ligature for the 4 and 3 grade hemorrhoids. About the type of device to use in the Doppler procedure, in the artery ligation procedure. This compare the THD with the HAL in 4 branch. There's other branch with PPH compared with M by Covidium, and only the number of ligatures with mucopexy was higher with the HAL compared with the THD, probably because without the Doppler we perform more mucopexy, and there's no morbidity difference at 90 days. Related to that, so we can defend that the type of device had little impact of the results between the THD and the HAL. Talking about the Doppler, is necessary or not necessary the Doppler, it's for the common sense that there is high variations in the arteries, in the hemorrhoids, so probably the Doppler will be necessary. But this study comparing Doppler and without Doppler, the HAL procedure has less pain in the first 2 postoperative weeks, mainly probably because there are less mucopexy with the Doppler, because we have exactly where is the artery than with the only mucopexy procedure. And it's interesting that they didn't find difference in the artery ligation between the HAL procedure and the mucopexy alone. So probably even with didn't use the Doppler, we also ligate the artery without the Doppler. The rate of recurrence was higher in the heart procedure, but there was no difference between the two procedures. About the artery ligation, where is the future and where is the limit? That's only to finish. This is a new procedure that, can you move the video a little bit forward, please? Excuse me? Can you move the video a little bit forward? This is an endoscopic treatment using a bipolar technique. Yeah, a little bit forward, please. Yeah, this is a special proctoscope, and as you can see, there is a bipolar, and it's very similar to the proctoscope with the heart procedure of the THD procedure. And the main benefit of this procedure is that the temperature that's achieved at the end of the procedure, it's about 55 degrees, lower than 150 degrees that we resolve with the infrared coagulations. Can we move a little bit forward, please? A little bit more. More? Yeah. Stop, please. Yeah. Okay. And just to finish, talking about a new concept of embolization and artery ligation and close the arteries. There is a few groups, especially in France, who make now embolization of the rectal superior artery with a femoral catheter with local anesthesia, permanently occluding all the branches that feed the hemorrhoidal plexus. And the biggest series of this group was 40 patients with a 75% of efficacy on the first day after embolizations, and with only 10% continued bleeding at 5 of 7 days. They can achieve the reduce of the hemorrhoid size very high, especially in grade 2 and 3, and the quality of life of all the patients are very high. So it's early to know what is the evolution of these techniques, because we need additional investigation about patient selection and the effectiveness in the follow-up, but maybe only with local anesthesia and with the development of radiologic embolization, maybe these techniques could solve the problems of our patients. To conclude, last year the ESCR described the clinical practice for hemorrhoids, and they recommend for 3 and 4 hemorrhoids the surgical excision, but in my opinion it's more accurate the Indian guidelines, who for grade 3 only in selected patients remains the surgical procedures, and for grade 4 only in the surgical procedures. As conclusion, I want to say that the dearterialization of heart is a safe procedure for grade 3 and 4. Now with the studies of our group, there is no inferior to Milligan-Morgan for 4-grade procedure. The THD reduced considerably the postoperative pain and analgesia requirements, and our main change now using the Doppler ligation on other techniques is looking for the less invasive procedure in hemorrhoids and assessing the needs of our 20th century patients. Thank you very much.